Thank you, Marla. Well, actually, when I accepted the invitation, I was in Boston, but subsequent to that, I moved on. Although I miss all my colleagues here in Boston, my nurses, and in particular my patients that I took care of for close to 29 years. Thankfully, some are coming south. I want to start this talk. These are actually my disclosures are in the book. I want to start by letting you know that I think each and every one of you are doing a good job in this area. As I give lectures to rheumatologists and dermatologists, I don't think this is really on their radar screen. Just recently, we've been seeing some publications in the rheumatology literature on how to keep patients safe on biologics and immunomodulators, but I think we're ahead of the game in the area of IBD, so you should all be congratulated. So basically, IBD patients, it's been shown, do not receive preventive services at the same rate as our general medical patients. And probably this is because the 21-year-old with ulcerative colitis or Crohn's disease often looks to their GIMD or their nurse practitioner or PA as their primary provider. And how often would a 21-year-old really need to see their primary care provider? They don't have any chronic illnesses, they have their IBD, and so they often will call us first. So it's really important that you clarify the limits of your responsibility. Make sure that you made it clear to the patient that if they have any IBD issues, any of their medication refills for IBD, they should call you. In addition, we'll touch on perhaps in one of the cases this afternoon, it is also important that if they really get sick with a fever or something like that, they can certainly call their primary care provider, but I want to know about that as well because there are unique infections that we need to think about that the primary care provider may not think about. So again, delegate these routine healthcare issues to the primary care clinician. If you're working with a primary care team, whether it be an EPIC or something else, you just need to make clear to them the unique issues that are addressed by our patients who are immunosuppressed. Again, that cold, that low-grade temperature that may just be an upper respiratory tract infection could end up being the first manifestation of a systemic bacterial or viral illness that needs early intervention. And I would argue that certain healthcare responsibilities, such as vaccination, be really taken on by us as gastroenterologists, and I have a solution for you at the end that will make your life a lot easier as opposed to just keeping vaccines in your office. Now, why is this an important subject? Well, basically, infections in patients with IBD are a real concern. Immunomodulators and biologics, and you heard earlier, as we stratify patients into high risk and low risk, we're using these agents earlier and in combination in some patients, not all. And there have been multiple case reports of both fulminant hepatitis and fatal varicella in IBD patients. So this is really something we need to be concerned about. Some, but not all, are vaccine preventable. And in the best of all worlds, we're going to be administering these vaccines prior to initiation of immunosuppressive therapy. So it's really that first office visit, a newly diagnosed ulcerative colitis patient, newly diagnosed Crohn's patient. I know you have a lot on your plate that you need to deal with, but if you have an order set of the various blood tests that need to be done, you will be able to kind of get started on the vaccination regimen. Now, why is this so important? These are two different studies that looked at the use of various drugs. On the left, it talks about drugs between 2010 and 2012, and you can see that half of the patients, this was a large administrative database study of tens of thousands here, N is 964,000 patients. You can see that half of the patients had received corticosteroids during that period of 2010 to 2012. A lower number were on long-term corticosteroids, thankfully, thiopurines, which we expect to go down, and then the biologics. And on the other side of the slide, you can see over time the use of various agents in patients that were followed. What's remarkable, though, about this data set, which was published in 2014, was the actually low rate of anti-TNF therapy in our UC patients. I think we certainly are moving more to anti-TNF therapy. So well over half of the patients will be exposed to corticosteroids. And again, we saw that pyramid from Dr. Ruggiero showing corticosteroids as being perhaps the most dangerous in terms of infectious complications. Now, if we want to look at specific infections, this comes from Millie Long. She looked at the risk of pneumonia in patients with inflammatory bowel disease. If you look at the lower part of the slide, you see in this kind of orangey color 126 cases per, I think, 100,000 versus 77. And again, you can go down the slide to see the rates. Overall, there's an increased risk of infection with pneumonia in all these patients, and these patients have worse outcomes. In addition to having higher rates of pneumonia, they have higher rates of being hospitalized and higher rates of ICU admissions. So this is a real issue for our patients. And you can see both biologics, thiopurines, and in this particular study, corticosteroids, which we kind of used repeatedly in our patients who are flaring, had the highest adjusted odds ratio of being associated with pneumonia. I think we'll have an opportunity at the end to talk about the new shingles vaccine. I think each and every one of us has seen the 21-year-old who's not even immunosuppressed with ulcerative colitis having shingles. The entity of ulcerative colitis or Crohn's disease by itself is defined as an abnormal immune system, and you can see increased risk of developing, for example, invasive pneumococcal pneumonia in IBD patients even prior to their diagnosis. In other words, they have an inherent defect in their immune system that increases their risk. So this is data looking at herpes zoster, again, across the board, higher rates in patients with IBD compared to non-IBD. And these numbers are now getting up there quite high. You see the lower figure, 734 cases versus 437. So again, a big issue, and we can talk about how some of our medicines, which are associated with increased risk of zoster, we can manage with the new vaccine. So this was a study we did in 2010 where we asked gastroenterologists, we did a survey, and 50% of them basically did ask about vaccinations. Again, this is 2010. I think we're doing much, much better now. At that point, there was significant problem in their understanding. In other words, in about a quarter of the situation, they would withhold inactive vaccines from immunosuppressed patients. So right off the bat, if it's inactive vaccine, everyone could get it. And another third of patients would kind of not know that the MMR was a live vaccine. And when we queried them, they would give the MMR vaccine to someone who was immunosuppressed, obviously something that we wouldn't do. And at that point, we were clearly, as gastroenterologists, delegating the responsibility for vaccination to the primary care provider. They basically said that it's up to them to decide, and 80% of the respondents said it's up to the primary care doctor to administer the vaccines. And about the same time, it was interesting, a paper was published simultaneously in Digestive Diseases and Sciences where they queried primary care doctors, and only about a third of them were comfortable managing vaccines because they didn't know what's the next medicine you're going to use in your treatment. They didn't know if the patient was going to be on steroids. So this basically put the patient in the middle of not getting the appropriate therapy. So the Infectious Disease Society of America, I'm looking forward whenever this is updated. This was published in 2013. It's a wonderful resource across the board, whether it be for HIV infections and other things that kind of talk about the various vaccines and the like. And basically they said that we as specialists caring for immunocompromised patients share responsibility with the primary care provider for ensuring that the appropriate vaccinations are administered to their immunocompromised patients. And they go on and talk about kind of what do you do for the immunocompromised patient whose child needs a live vaccine or whose mother is getting a live vaccine. So the best practices in vaccination, the ideal time to obtain a vaccination history is during those initial office visits. If you can't get it done the first one, but soon thereafter. In the best of all worlds, we're going to vaccinate our patients prior to starting immunosuppressive therapy. And this is a kind of key thing that we've been doing, and I think this is why we're doing better in general in terms of vaccination. I understand that if you're in private practice, storing vaccines is a big issue. You need to have the refrigerator monitored. God forbid the power goes off over the weekend and you lose $10,000 worth of vaccine and you're responsible for that. So at BU, we offered vaccination in our office. Our nurses did that, and at Mayo, we actually just write a prescription. They go down from the 6th floor to the 2nd floor and they can get their vaccines. But in situations where you can't do that, just write a prescription and send your patient to their community pharmacy. You know, you can basically, they're open 7 days a week, not necessarily 24/7, the pharmacy, but they're open 7 days a week, and the patient with the prescription can get their vaccine. They can show up, the pharmacist can run a claim to make sure there's a fee or no fee, and we've all seen the signs, come in for your flu vaccine at the local CVS. And the quandary is, you now have a sick kid who basically is not immune to measles, and you found that out because his antibodies were tested and he never got the vaccine, and now he needs an immunosuppressive agent. We don't have the luxury of time of waiting to give the vaccine to begin their anti-IBD therapy. So again, necessary IBD therapy should never be delayed in order to administer vaccines. So let's look at some practical things. The good news is an adult gastroenterologist, although this slide's kind of old, IBD is rare before the age of 5. I think Marla can tell us about more and more kids that are diagnosed at 2 years and 3 years, but in general, for the patients we see, IBD is rare before the age of 5, so most patients would have received all their childhood vaccines. So for us, as adult gastroenterologists, we need to think about hepatitis A, hepatitis B, HPV, influenza, the pneumococcal vaccines, shingles, and varicella vaccine. So the first question is, will the vaccine cause an exacerbation of their underlying IBD? Dr. Farraye, you just told me I have an altered immune system and my immune system is attacking my intestines, and you want to give me something that stimulates the immune system. Isn't that kind of, counterproductive? We can reassure patients that there's absolutely no data that would convince me or anyone else in the literature that vaccination is associated with an exacerbation of their IBD. We can talk about the shingles vaccine, which is a unique situation at the end. So basically, no evidence that it will exacerbate, but if your patient is on combination therapy, many of these studies, if you can look at the dates, were in the era of combination infliximab, adalimumab, and thiopurine, there is a decreased immune response. That doesn't mean the immune response will not protect the patient, but it may be a less durable response. So this is our article that was published in the American Journal well over a year and a half ago now on preventive care, and we addressed both vaccinations as well as other areas. In addition, every February in the Annals of Internal Medicine, a free download, the ACIP recommendations are updated in terms of vaccines that should be administered to patients who are both immunocompromised or immunocompetent. So let's quickly kind of go over the inactive vaccine recommendations, and this obviously is regardless of immunosuppression. Influenza is recommending for everyone yearly. The TD or Tdap is one dose and then TD every 10 years. We're going to spend some time discussing the RZV, which is the new shingles inactive vaccine, and it's preferred over the old vaccine, which is Zostavax, the HPV vaccine. Again, the old Zoster vaccine, which is Zostavax, which is a live vaccine. HPV is 2 or 3 doses depending on the age of onset in women 12 to 26, though the FDA recently approved the HPV vaccine for patients up to the age of 45. The ACIP, however, have not yet kind of promoted this or recommended this, so we'll probably have to wait till next year. We'll talk about PCV13, which is Prevnar, and then PPSV23. I have a little diagram from an article that was written by Millie Long that you can look at and perhaps keep in your office. There's a specific order in which you administer these vaccines. Hep A and Hep B, 2 or 3 doses. I'm going to talk about the new Hep B vaccine, which is a vaccine we're now using in our office at Mayo for patients who are immunocompromised, and you can use it for all patients. Now, when you start talking about live vaccines in immunocompromised patients, you need to determine whether the patient has a high level of immunosuppression or a low level of immunosuppression. And this comes from that IDSA paper I told you about in 2013 or 14, Infectious Disease Society, and this was also modified from something that Bruce Sands put together. He put together a series of experts, but that was actually published in 2004. For the most part, low-dose immunosuppression, the doses of methotrexate that we use, the doses of 6-mercaptopurine, that's considered low dose. And we were able to actually give the live shingles vaccine to patients on low-dose immunosuppression. Same thing for the live chickenpox vaccine, low-dose immunosuppression. But once you start getting into things like anti-TNFs, potentially the IL-12/23 inhibitors and the JAK inhibitors, then we're talking about high level of immunosuppression. You do want to avoid live vaccines. The other person at risk for infectious complications are these folks that have protein-calorie malnutrition. So the person who's got an albumin of 2.8, those patients should be considered immunocompromised. So this goes over again from the Annals of Internal Medicine 2019 February paper, and then a review article that we did, the various vaccines in immunocompromised patients. So let's just concentrate on the red ones. So MMR, that's measles, mumps, and rubella. It's hard to go not read the newspaper and realize about the new kind of outbreak of measles throughout the country, and this is a real issue in terms of our 18-year-olds that are going to college or high school, and they don't longer have the herd immunity of having everyone else vaccinated. But measles, mumps, rubella is a live vaccine, and we should not be using that vaccine in our highly immunosuppressed patients. Again, I'll talk about the new shingles vaccine and then the chickenpox vaccine. So it's an issue with chickenpox you should know about. Antibodies to chickenpox to varicella will wane over time. So the way you determine if someone's immune is by just determining whether they received their childhood vaccinations. If they received their childhood vaccination for varicella or chickenpox, they should be considered immune. The antibody actually may be negative. The time to check the antibody is someone who has no history of ever being exposed to chickenpox or never receiving the vaccine. But for all the boomers in the room, my mother took me to the chickenpox party when I was 3 years old to make sure I got chickenpox when I was a little kid and not get it when you were 18. But again, varicella antibodies should be tested in patients who have no history of chickenpox or no history of receiving the vaccines. So let's talk about the new hepatitis B vaccine. It also has an adjuvant that makes it highly effective. It's a 2-dose hepatitis B vaccine given over 1 month as opposed to 6 months. So it's a more rapid development of immunity. It's a yeast-derived vaccine prepared with this adjuvant. Again, it's recommended for all individuals over the age of 18. Seroprotective anti-HBs antibodies for this versus the standard Engerex B vaccine. 95% of patients were immune after the 2 doses versus 81.3% of individuals receiving the 3 doses. So clearly an effective vaccine. Some kind of signal yet to be seen and yet to be corroborated whether the adjuvant is associated with any flares of any immune-mediated adverse events. At this point, I certainly am comfortable using this new vaccine in our patients who are immunocompromised or immunocompetent patients. Again, we do need data on patients who are receiving this vaccine who have IBD. The Zoster vaccine, again, it's now been approved to be indicated for individuals 50 and above. It's 2 doses, 0.5 mLs. It's given IM, first dose, and then the second dose 2 to 6 months. This is a remarkable vaccine. Again, this was published in the New England Journal of Medicine. This study did include some IBD patients and rheumatoid arthritis patients and lupus patients. It was a tiny percentage. None of those were immunocompromised, though. But for the most part, look at the efficacy of this vaccine, 97.2% compared to placebo over time. So this is an extraordinarily effective vaccine. This is data up to 3 years. There's now new data coming out suggesting protection up to 8 years. And the problem with the Zostavax vaccine, the old vaccine, was that immunity waned pretty quickly. And so by 5, 6, 7 years, you were seeing a waning of immunity. And what happens to shingles? The risk of developing shingles is a direct line up. It just continues to increase. So if you give the vaccine at 60, which is an appropriate time, it was recommended by the ACIP for age 60 for the old shingles vaccine, by the time you're 70, you may not have immune tolerance anymore, and the risk is going up over time. Again, this vaccine, if you've been fortunate enough to get it, I've managed to get my 2 doses over 6 months. About a third of patients do have significant immune response in terms of local swelling, pain, low-grade temperature, myalgias. The first dose doesn't predict the second. My recommendation would be to kind of get it on Friday afternoon at CVS if you can get it. Take a dose of nonsteroidals and kind of sleep in the next morning and take another dose if you're that 1 in 3 people who have significant side effects. But for the benefit of 90%, 95% protection for the non-IBD patient, I think it's well worth it. So what did the ACIP say about the new shingles vaccine? Basically, they met, and these are their recommendations. The new vaccine, recombinant zoster vaccine, is recommended for the prevention of herpes zoster and related complications in immunocompetent adults greater than 50. They said immunocompetent adults. We'll talk about my preference and how I do give this vaccine to immunocompromised patients. We really need the ACIP to really kind of rise to the occasion and give us some specific recommendations. It's recommended for the prevention of herpes zoster and related complications for immunocompetent adults who previously received the Zostavax. So if your patient got the live zoster vaccine, they should still receive the inactive vaccine. And they came down, this was more of a split dose, a split vote rather. The overall winning vote was that it was recommended over the live vaccine. So in these days, I would just administer the inactive vaccine to our patients. I told you that I would have this handout. This should be in your handout that just talks about the order of giving the Prevnar, which is the PCV13, and the PPSV23. I won't go through it, but this is a useful resource so you know the order to receive these. Again, if you have a patient leaving the country, I just send these folks to the ID clinic and the travel clinic. Let them decide which vaccine should be administered. And we do have issues with some vaccines, in particular the yellow fever vaccine, which can't be administered to patients who are immunocompromised. Again, this comes from Cornerstone's excellent checklist. This is updated periodically. This is the 2017 update. They also have this in Spanish. And again, it talks about everything from vaccines to other things you should be doing, from looking for cervical cancer, skin cancer, and the like. And this comes from the Crohn's and Colitis Foundation. This is updated yearly. I just checked on the website. The link is broken. I pointed that out to the Crohn's and Colitis Foundation, so the new updated vaccine should be there. So my title was Vaccinations in IBD, What, When, and Why. Well, what is several different vaccines. When is ideally before immunosuppression, but don't miss the opportunity to update vaccination at all encounters with our patients. And the reason why we're doing it is to keep our patients safe. Annual vaccination against influenza, Hep A and Hep B. We talked about the pneumococcal vaccine. Again, it's recommended by the ACIP to give this in patients who are immunosuppressed, but I actually administer it to all my IBD patients regardless of age and regardless of immunosuppression, because I pointed out earlier this group of patients is at increased risk of developing invasive pneumococcal disease despite even before receiving any immunosuppressive therapy. We've not had any pushback. Again, if the patient goes to their CVS and there's a charge, they can decide if they want to do it. Vaccinate with Shingrix in all patients over the age of 50 and potentially younger. Many of us have been giving this vaccine to patients who had previously had an episode of shingles, regardless of their age. It's $160 in the typical pharmacy times 2. Your patient may decide to receive the vaccine and pay out of pocket. Again, although there are no specific recommendations regarding the vaccine in immunocompromised patients, it's an inactive vaccine. There should be no reason why you should not administer it, and we have administered it to our immunocompromised patients. I pointed out the issue of varicella vaccination. Again, if there's no history of receiving the vaccine as a child and no history of chickenpox, then do the serology. But if you do the serology in everyone, you will find patients who are seronegative who truly are protected against the development of varicella. And again, I mentioned the HPV vaccine, presently 18 to 26 and possibly to age 45. Our IBD patients have poor immunization rates, so ask. I think we're doing much better than we did in the past. Again, vaccinate prior to initiation. One of the issues, again, in the best of all worlds, by doing this prior to an immunosuppression, you'll get higher antibody titers. IBD disease activity will not be affected by vaccination. We pointed out the checklists. And again, take responsibility to vaccinate your patients. But again, if you do not have this in your office, go ahead and just write a prescription, print it out in Epic or wherever, and have your patient go to the local pharmacy to get their vaccination. Thank you very much.